Okay, commissioners, whenever you're ready. And Commissioner Chow, would you like me to call out the items, or would you like to call out the items?
No. Why don't you call the items? That works just not only better, it works better.
Okay, that's great. And please make sure that both of your microphones are turned on. I'm not sure if they need buttons.
I
Some of
just
them.
did, right. And this will, it's so much easier the last time with everybody just watching. But in any case, we'll call the meeting to order. The Joint Commission, the Joint Conference Committee for the March the 28th.
Yes.
And we welcome everybody finally in person. We had hoped we would be at Carr Auditorium, but I gather that we're still working out the audio. Not that the audio is that much better here, but the reason some of us are using the headphones is that it's very hard to hear because of the acoustics in this room at the moment. And Mr. Morwitz assures me that we're going to have that fixed in the coming months.
Hopefully late summer.
And we're hoping that you will all do our Carr Auditorium likewise, so that we could actually have our joint conferences back there, of course, and see you all. I think it's been over 3 years that none of us have been able to actually hold our meetings there, and some of us have not even been down there for that period of time. So we're all anxious to see what the campus looks like now, and the trees are probably bigger, and I'm sure that the UC building is looking like it was nearly complete, at least the exterior, when we got the report. So we'll look forward to being down there with you all in the next several months. So we will proceed to call the roll.
Yes, sir. Commissioner Chow?
Present.
Commissioner Green?
Present.
And I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community, and by affirming their sovereign rights as First Peoples. The second item on the agenda is the approval of the February 28th, 2023 ZSFG JCC meeting minutes.
So we're prepared to entertain a motion for the minutes that have been circulated with some edits.
So moved.
And I would second.
Great. There's a person on the line. I just want to make sure, person on the line, if you'd like to make a comment on any of the items, please press *3. We're on item 2, so please press *3 if you'd like to comment on the minutes. All right, no hands, and since there's 2 of you, that takes action, so we can move on to item 3, the Regulatory Affairs Report.
Okay, thank you.
Hello, how's that as a volume? Is that all right?
A little closer, please.
A little closer, how's that? Okay. My name is Emma Moore. I'm the Director of Regulatory Affairs, and I'm here to provide the Joint Conference Committee report for March. So in terms of pending surveys, you can see one update is that we have scheduled our American College of Surgeons Level 1 Trauma Certification. So that will be July 12th and 13th. We also have the baby-friendly hospital survey that we do not have a distinct date yet for, but are hopeful we will have that shortly. So that is coming up soon. From a survey activity standpoint, I know I mentioned this briefly last month, but would like to give additional updates about the Joint Commission Primary Stroke Program Certification Survey. So there were 3 findings. 3 findings, all documentation related, so nothing related to direct patient care. And there was a finding related to frequency and documentation of neurochecks, neurovascular checks, and vital signs. One about accurate medication administration route, so the best way to describe that would be medications being given via an NG tube when the medication was ordered orally. So again, the surveyor underscored during this finding that she had no concerns about appropriate care delivery, but simply from a documentation standpoint, she noted that as an issue. And lastly, medical record completeness and accuracy, so conflicting orders on blood pressure management, that there were multiple orders in place at the time. So we are in the process. This Joint Commission blessedly gives us 60 days to respond, so this submission is due on April 16th. We have an interdisciplinary team for these three findings that is actively working on a solution for these. On the second page, apologies, just trying to stand as close to the microphone as possible so you can hear me. On the second page, you can see that we've had a total of 126 reportable events. Again, this data is January and February. So in total, we have 6 reported events in 2023, and for the month of February, there are 3 there. So you can see that there was on H66 a COVID outbreak that was well contained once it was identified. There were also 2 reportable pressure injuries, one an unstageable and one a stage 3, both on H34, one of the ICUs. And then lastly, on our plan of correction monitoring data, you can see we have two things that are undergoing current monitoring. So the first is a rather old incident related to a Belmont Rapid Infuser that was a facility reported event, and the monitoring that is going to be going candidly in perpetuity is completion of HIPAA confidentiality training. So within the DPH employees, you can see there that we are greater than our 90% threshold that we were required to meet, and UCSF employees, that is what is a continued ongoing monitoring that will be going for the foreseeable future. The second item here is a CDPH self-reported pressure injury plan of correction. So the pressure injury occurred in May, June of 2022, but we received the plan of correction in January, and there were 2 findings. One, a delayed reporting of the event, and secondly, failure to renew the reporting policy. So the policy saying we call CDPH was past its 3-year review date. So the monitoring to address the delayed reporting of the event was we did for August, September, and October, because that was immediately after the exit of the surveyor. We did a cross-reference with the wound care service and the regulatory affairs team, and successfully confirmed with 100% accuracy that every identified pressure injury had been reported. So that monitoring is complete. But the second item was to do audits, 10 audits per month for 3 months until we achieved greater than 90% compliance of identifying that all of our ZSFG administrative policies were within the 3-year renewal process. And I will report that you can see there the February data indicated 60% compliance. That was a random sampling of the first set of admin policies, but in February, and as soon as our PIPS policy, our PIPS meeting minutes have been ratified, that we have passed through approximately 70 policies, so greatly increased our approvals in the last 2 months. So I am hopeful that within the next quarter, we will be all administrative policies will be within the required 3-year turnaround, and that we will then tackle as expeditiously as possible the environment of care policies as well. What questions might I entertain?
Thank you for the report. I have 2 questions. What's an unstaged HAPI?
An unstageable HAPI is, and I would defer officially to our wound care nurse, but it's one where they're able to tell that it is the layman's version, they're able to tell it's a severe wound, but they're not necessarily, based on the eSCAR and the depth of the wound, they're not necessarily able to distinctly stage it. So they're not able to say that it counts as a stage 3 or a stage 4 or a stage 2, but it does fall within that severity, thus it is reportable. So reportable HAPIs would be a 3, a 4, or a unstageable. 1s and 2s are just subject to monitoring and care.
Thank you. And then, do you have any sense now that the emergency is being lifted when some of these pending surveys might occur?
That is a great question. The short answer is no. But what I will say is that, we've definitely been hearing inklings of, that, for example, a lower level survey that's not, or less intense survey, I would say, not lower level. But for instance, the DEA we've heard is kind of around and about, and our pharmacy is due for a visit. And so we kind of, from our fellow hospitals, kind of get so and so was here a couple weeks ago. They might be in the window. So we have identified that sort of there is increased activity, but I unfortunately cannot give you any concrete information as to when exactly they will be there. I will say from a survey prep standpoint, we are very much attempting to be methodical and calm in our preparation because we don't know when they're coming, but it is very much in the back of our minds every day that they could show up at any time.
Thank you.
Yes.
In follow-up on that, where we have the acute care hospital survey pending, when was our last one?
For CDPH,
Yeah.
it was March 1st through the, I think, 5th of 2020. And I remember that vividly because they exited the hospital when we got our first COVID patient within about 2 hours.
So is there a rhythm that they normally have? Because you say approaching 2023. So is it that it's a 3-year period of time that they, okay.
Correct. It is a 3-year cycle. They have, I think, categorically within the state identified that they are behind. There was a point when they pulled back from hospitals given the emergency. And so it really remains to be seen when they identify that we are a priority. So I think they're in the process of catching up because, as you said, it is a 3-year cycle. But again, if, media, whatnot, they may decide to or reported incidents, they may decide to reprioritize their visit to us.
All right. And what about the Joint Commission survey? When
Sure.
would you expect that? That's not listed on here.
It is actually, it's right below that general acute care.
Oh,
And
sorry.
it is also on a 3-year cycle. We last had it 2 years ago,
Ah.
but that was a year late because of the pandemic. And so that window opened in November of 2022, but candidly, the window they've given us goes through May of 2024. So we have more than a year open of our window, so they really could, it's as wide of a window as it could be.
To 2024, you have our 2023 listed.
I do, thank you. That is a typo. I will fix that for next month, apologies, and I will send an updated copy to Mark.
So it's actually 2024.
Yes, 2024, thank you.
Okay, and I missed that because TJC is an initial I'm not as well acquainted with as the old JCAH. And
Yep,
so forth.
JCO is still very much emblazoned in most of our staff's minds. Honestly, when we come around to talk to them about survey prep, it's a common name.
So in the COVID incident that you reported, did they or have you found the source of how it got into the unit, or because Laguna does that, right? They sort of try to figure out, although it's very difficult, but whether it came from staff or whether it was a resident and so forth.
Yes. So we have a fantastic infectious control team. They attempt to do epidemiologic investigations of each event. I'm not aware in this case that they were able to identify a patient zero, so to speak, however.
Okay. All right. And I guess the HAPI continues to be a problem, as we're all aware of, and everybody's working on it, so thank you.
Exactly.
Okay. I have no other questions. Did we have public comment on this yet?
I haven't yet checked. A person on the line, if you'd like to make comment on this item, the regulatory affairs report, please press *3. No hand.
Okay. If not, then we can go on to our next item.
Great, thank you. Item 4 is the True North scorecard presentation, and give me 2 seconds to pull it up on mine. Chris, do you mind taking the mouse and dragging the bottom picture just outside of the view? Yes. Great, just so it's not messing with the data. Thank you.
Hello, Commissioners. I'm Chris Ross, a Strategic Planning Manager in our Kaizen Promotion Office. Today we are presenting our True North scorecard for calendar year 2023. This is the representation of the metrics that we have set forth in our strategic initiatives. These are our targets and goals, as well as our longer-term True North outcomes. So what we'll do today is walk through each of these metrics. We haven't quite shared these with you all yet. Each of the strategic owners will share the strategy behind their KPI, the metric for their key performance indicator or KPI, as well if we are on or off target for the first couple months of this year. So I will start and I will turn it over to Susan.
Good afternoon, Commissioners. I'm going to start by speaking about our equity driver. This is a driver that is familiar to you because we had it all last year. And as you recall, all last year, we were on target and we were achieving target. It was a pretty aspirational goal, we had thought, but we actually did quite well because, oh, there we go.
It comes and goes.
Okay. We actually did quite well because our departments were so engaged. Recall, this is the percent of departments presenting to our PIPS meeting who have chosen a driver related to equity in their departments. At this point in the year, we are off target because we have a lower percentage of departments that have chosen drivers than our target, which we've actually increased from 50 to 60%. What we are doing to try to address this is we have a very robust and complete way of coaching departments as they are preparing their PIPS reports. So we have, and we encourage them very directly, as you know, because you see the PIPS report, to choose equity metrics as drivers. So we expect that with that, we should get to our target of 60%. Thank you.
Good afternoon, Commissioners. I'm here representing the Achieving Safe and Equitable Patient Care work that we are doing. Lisa Winston is my executive partner, and she's not able to be with us today. We're following 5 outcome metrics that are patient-related, and the work that underpins that contains a lot of process metrics around rebuilding the patient safety program and revitalizing the teams that are working on these patient outcomes. So we have 5 outcomes. We have catheter-associated urinary tract infection, central line-associated bloodstream infection, colon SSI infections, hospital-acquired pressure injuries, and falls with injury. And we've expanded the falls with injury to include all inpatient areas of the facility this year. You'll see that these metrics are very similar to the ones we were following last year on the HARM dashboard with the addition of HAPAs. We are green in 2 of our areas. One is CAUTI, catheter-associated urinary tract infection. Our target is a rate of 2.26, and we're achieving a rate of 1.93 right now. And for colon SSI, our target is a rate of 1.62, and our current rate is 1.08. For CLABSI, we're over our goal, which is 0.77. Currently, we're at a rate of 1.69. For hospital-acquired pressure injuries, we hope to achieve a rate of 0.20, and we're currently at 0.39. And for falls, we hope to achieve a rate of 0.45, and we're currently at a rate of 0.61. I can share with the Commissioners that our falls rate is it's successfully falling each month, and we are in the process of looking for other benchmarks that we can use to address that. And I just want to share with you that when we come next time to present this data, our HARM dashboard is going to have our overall harm stratified by race and ethnicity to move towards our equity goal.
Good afternoon, Commissioners. Luke Day and Jillian Otway here. We are presenting our True North metric around quality and access. And this is really focusing on improving patient flow throughout the ZSFG campus. As you can see, there are 3 KPIs that we are currently following. Ambulance diversion within the emergency department, third next available appointment in our outpatient clinics, and then a lower level of care for our med-surg patients. We've made significant improvement in each of these KPIs. With regards to ambulance diversion, you can see that we are green. So we are below our 50% target. We are now hovering at around 42, 43%. That has been sustained even as of this month of March. Second, for our proportion of adult outpatient specialty care clinics, which is 60 of them across our entire campus, our goal is to have 90% of them with the third next available appointment under 21 days. We are technically off target. We're about 87%. However, if you drill down into the data, there are about 5 extra clinics that are within 2 days of that 21-day target. So if we include those, plus or minus a little standard deviation, we are over 90%, which is pretty remarkable, I think, for 60 clinics. And then finally, our lower level of care patient days. We are red on this, so also off target, but you can see that we are making progress. The number is declining. We don't anticipate that we'll meet our target over the next couple of months, given a number of disposition challenges for our patients. With regards to work that is ongoing with each of these KPIs for ambulance diversion, we have done some standard work around activating ambulance diversion and have a robust staffing plan that is aided in that green metric. For third next available appointments, I think you've seen in some of the reports here, weekend clinics, additional clinics, doing more patient education and telehealth. And then finally, for lower level of care, we have about 15 different countermeasures that we are currently working on to try to improve our lower level of care days, many of which are really trying to find improved disposition options for our patients. Thank you.
Hello again, Commissioners. Andrea Turner owns this next strategy, but she cannot be here today. She is on the line, though. Our Achieving Safe and Equitable Staff Experience strategy is focused around our workplace violent events, specifically physical assaults with injury. The metric for this particular strategy is still under construction. As we switched over our UO system to the SAFE system, there are some nuances we are still working through to develop a robust metric and to get validated, accurate data. But I will say that we, again, are focused on physical assaults with injury. So more to come on this one. When we have that A3 fully fleshed out with the metric established, we'll bring it back to you all to present and give an update, similar to how we presented the flow strategy last month.
Good afternoon, Commissioners. Jennifer Boffey, Chief Financial Officer, and my co-lead, Jenna Belinsky, the Chief Integrative Officer, is on the line. We're here to tell you about our revenue cycle A3 for finance, which is optimizing our revenue cycle. We are currently developing our metric right now. So as you know, we switched to fee-for-service in January. We will be looking at the % of denied claims. As of April 1, we will be able to collect the first quarter of data, set a baseline, and go ahead and set our goals and targets. We will come back to share those with you the next time we present our A3. At this time, we don't anticipate any barriers or challenges with our A3. Thank you.
Hello again. So I'm going to talk to you about our True North outcomes, which are the longer-term outcomes that we expect to achieve over the next 3 to 5 years. All the work on the strategies that you just heard about are 12 to 18-month strategies that all drive improvement in these longer-term goals. So these will look semi-familiar to you. A couple of changes I wanted to point out to you to start. The first is that we have added a care experience long-term goal because we think that's really important, and we've identified work in all the strategies that we're working on that will help drive that. The second thing that we're really proud of and is consistent with our goal to stratify all our data is that you can see that all these 3 outcomes, where it's possible, we have stratified by race, ethnicity, and language. And before you ask me why we see the disparities we do, I can tell you we do not know, but having the data is the first start. And it allows us to ask the questions we need to ask in order to dig in and really understand them better. So just a little bit more on these. The specialty clinic and outpatient care experience is a mix of our HCAHPS hospital data and our real-time patient experience data. The real-time patient experience data has been relatively recent, and allows us to have a response rate and data that really gives us more information about what our patients are experiencing. The staff experience survey that we're in the process of responding to right now, and I will say that at last count, ZSFG is at about a 40% response rate. I know the department's goal is 70%, but even 40% is a really good response rate. And if we got no better than that, we would have great data that would inform us. But I know we're going to try to keep getting more and more surveys. The general fund metric is focused on a fiscal year basis, so we'll continue to have updated metrics data on that, and you can see that one is in the green. Going back up to the CMS star rating, this is one that, of course, we've been in the red as long as we've had this. We're still at a CMS 1 star. We will be getting data within the next couple of months, the new updated data, and that's going to help inform us on our quality metrics and all of the work, actually, because most of what we're doing contributes to us improving in that area. You know, the star rating is a quite large and diverse metric, and most of the things that we're working on in the 12 to 18 month strategic area contributes to that. So we'll try to really focus in on the areas that we're doing the worst in and focus our work in those areas. That is the end of our presentation. I just want to say how grateful I am to our team for pulling this work together, for really focusing on the things that we know are the most important to drive patient and staff experience and safety and quality on campus. And I'm happy to answer any questions or defer to my colleagues who are much smarter than I am and can probably do a better job at that.
Thank you. Let's check for public comment.
Sure. Person on the line, if you'd like to make comment on this item, let's see, we're on item 4, the True North scorecard. Please press *3. No hands, commissioners.
Yeah, Commissioner Green?
Well, this was a wonderful presentation and excellent work. And as I look at some of these things, like the numbers for the central line, they're small numbers, and it looks like, you know, the achievement is remarkable. And I was really impressed by the diversion rate and the lower left without being seen data that were presented that I think you'll talk about in your report, especially in the context of the issues we're having finding lower level of care beds. So this is really terrific. I wonder if you could elaborate a little more on the STAR thing, because as I recall, isn't there a lag between the data they're using to award the STAR is a lag, and wondering whether there's, you know, with COVID in particular, which maybe the data that relate to the most recent STAR rating is affected by, you know, this whole COVID situation across the country. Can you fill in a little more background about like what data is used when, and whether there's any changes based on what you can and can't do in a COVID environment and so forth?
This is one I could speak to at a high level, but Adrian is much better able to.
And there are others that can speak in more depth to it than I, but you're correct. The data that they use to drive the score is between 3 and 5 years old. And the targets that we were working towards based upon star ratings 2 to 5 years ago are not the same things we're being assessed against now. On top of that, we were not required to submit some data points during COVID because it was, we were given kind of a break because of everything else we were doing. But that means that we're using even older data to make the assessment this year. So there have been, many of the hospital associations across the country have reached out to CMS and said, is there any way for there to be a fairer reckoning of star ratings? And CMS have not responded at this point. When the new ratings come out, my team are going to do a deep dive into what they look like and whether, if the data that we continue to collect but did submit would have made a difference to that, and we'll share that information with you when we have that. Does that answer your question?
Yes. I mean, when do you expect new ratings to be published?
I think that's a question that I don't have an answer to. We expect them usually in the first half of the year. Historically, it had been in the first quarter of the year, but CMS, like the rest of us in healthcare, are catching up and refining old ways and doing them differently. So we're expecting it sometime soon, but we don't have a specific date.
It's so unfortunate because if there's a disconnect, it's between the star rating and the quality of care that's given at the county. It's so frustrating to see that all this wonderful work is not adequately represented by this scoring system. So, we certainly think everything you do is terrific, and hopefully CMS will come around and see it our way as well. I think that was the main question I had.
Yeah, I think this 1-star, 2-star thing has always, in all the years we've been here, been a real issue. Part of it also related to the way that the standards are written, and another is related somewhat to the type of institution that we're at, to which the standards do not. And I understood in the past that we were trying to make, or the associations were trying to make some sort of a difference. Has that gone anywhere in terms of a better understanding? And I know Dr. Ehrlich was discussing that, I believe, last year when we were talking about the 1-star.
I would say yes and no in answer to that. On the one hand, associations have advocated successfully to Congress that the star rating doesn't reflect as well the experience in safety net hospitals for all the reasons that we know of. And CMS have made some changes to the star rating, but they haven't really adequately addressed our issue. And it is possible for safety net hospitals to do better than 1-star. I mean, basically, the star ratings are distributed on a bell curve.
Yeah.
And if you look at safety net hospitals compared to all hospitals, the whole thing is just shifted to the left. So we know we can do better, and we always aspire to do better. And so that's why the star rating stays on our scorecard, even though we know there are problems with it. And we've had endless arguments about whether it should be or shouldn't be there, but it's such an important industry standard that we have chosen to leave it there.
Good, you answered my other question. Actually, I couldn't remember if we actually are scored on a curve, which makes it even more difficult. But I think that when we get to that deep dive this time, maybe we should take a deeper look at it at the commission level in order to more fully understand what is happening, because you're always constantly doing this wonderful work, as Commissioner Green also pointed out. We know the quality is there, and this is just a horrible way of reflecting it to the public. And as you say, that is a public indicator being used more and more as, competition between systems and all continue. And it doesn't give our public good confidence, even though, individually they know that our patients get good care. So I would agree. And if we could take a look at what you all think you're finding and how we may deal with it, because certainly what we're doing doesn't seem to get reflected into that. So I do think that the new areas of emphasis, I really do agree with, especially care experience. I think that is very important for us, and this is where the racial and equity issues probably rise the highest in terms of trying to understand that. And it seems to me that we will learn a great deal from that in terms of it helping to identify and understand the care experience that people are having. So really appreciate that, and those are the three things I took out of it. On a small point, it's really small, and yours is even bigger, see, so if we could have gotten a bigger copy, it might have been easier. At least for some of us who are having more problems. It looks like Commissioner Green was able to read it much, but I took out my magnifying glass and really.
I mean, it can easily be printed on A3 paper, which is the standard way that we do it. It's just, it's a photocopying thing. So, we can certainly provide A3 paper for this. I agree. I had to reprint it on A3 myself.
Okay. And knowing that this is the beginning of the year and it's based on a calendar year, obviously, there's a ways to go. And I think the real message here is how much in depth we are looking at the real quality issues that come out of your True North that you're using. And that, again, I mean, these are the types of things people should really be looking at, how well we're doing and not some of the other, well, we'll find out from your in-depth.
Yes, we will.
Where we seem to be failing. Thank you.
You'll see it every month.
Okay. Thank you very much. Mark, let's go on to the next item.
Sure. Item 5 is a CEO report.
Ah.
Hello again. Okay, so I will, as usual, I'll go through the narrative and we'll give you an opportunity to ask questions about that and then move on to the data, which I do have some things to say about, especially related to access and flow. So I wanted to just talk about COVID for a minute. It's not exactly reflected in this way in the report, but I did, because we have some changes coming up that people will be talking about. I wanted to just make sure that it was clear for the both of you. So on April 3rd, the state health orders will end, which is basically the state handing over the ability to do these orders or not to local governments and local health officers. Here in San Francisco, there will be, at the time the state orders expire, Dr. Phillip has new health orders, only 2 though, and they both relate to us at the hospital. I think you've heard about these, but I just wanted to make sure that you were aware of how they impact us at ZSFG. So one of them relates to masking, and the second one relates to vaccination. The vaccination order is basically a restatement of the way things were before. People who work in healthcare facilities and high-risk settings need to be vaccinated with the first 2 vaccines plus a booster. Booster is not specified. With respect to masking, masking is still required in high-risk settings, namely hospitals, skilled nursing facilities, and jail, in patient care areas. And so our rules at ZSFG basically reflect that order. And what that means is that in any area of the hospital where patients are present, so that includes the lobby, elevators, hallways, any place a patient could be, everyone is required to wear a well-fitting mask. In areas where patients are not present, it is optional to wear a mask. So that's relatively new for us, and it is the same as the health order. So what that means is, say in the 7th floor conference room where we used to have our JCC meetings, mask use is optional there. Or any space like that on the campus. There aren't that many, but there certainly are places where patients are not present. So that is the main change that's upcoming in April. I think we'll face this again in May when the federal health emergency ends, but for April, the state and local orders will be changing, and on our campus, it's pretty much going to stay the way it has been for a little while now. We reflect on the staff engagement survey. I really want to call out our communications team for doing some really nice oral history of some of the women leaders we have on campus. These have been coming out this month in the Daily Digest, and it's a really lovely way to highlight the women who are leading and working on our campus. And then we have a couple of healthcare recognitions. Thank a Resident and Fellow Day, Food Nutrition Team, and of course this Thursday, and you'll read about it next time, is Doctors Day, National Doctors Day. That's it on the narratives. I'm happy to answer any questions.
See, Mark, do we have any public comment on the report?
Folks
from-
on the line, if you'd like to make comment on the CEO report, which is item 5, please press *3 now. *3. I see no hands.
Commissioner Green, I think we should go ahead and then we can,
Pardon?
I was thinking we'll go ahead with the data
Sure.
and then we'll go into the
Yeah.
full report in depth. Thank you.
Okay. So heading into the data, we have this beautiful representation of our now into our 7th COVID surge. The first one is off the page to the left. What's interesting about the 6th and the 7th is they both have these bifurcated peaks. I don't know what accounts for that, but we've been pretty stable in the hospital recently. We have 12 patients in the hospital today, none of whom are in the ICU, and that's been kind of a steady state for us for a while. Moving on to other important pieces of data. So the emergency department, as you can see, is busy. I looked at the data month to date for March, and we're tracking to 191 on average. So we can expect that the next time you see this report, it is going to be busier than before. I have been really curious to look back and see how we are doing since, before the pandemic. And on this day in 2018, we were tracking month to date to 206. So we're getting right back up to pre-pandemic levels of busyness. Average daily admissions is going up both because we're busy and also because our diversion rate has been going down, and we'll talk about that in a minute. In fact, right now. I think the most interesting and very hopeful part of this report is on page 7, where you can see the leave without being seen rate is now down to 6.8%, and the diversion rate is down to 45.1% for February. We're actually tracking below that for March. There are likely many reasons for this. I think the most significant reason we've been able to do this is because we've been much more reliably able to staff the emergency department. So we track to what we call core levels of staffing, and for a very, very long time, we have not been at core, but in the last couple of weeks we have. Now that's primarily because we've been able to bring in registry nurses and temporary nurses, but for right now, it's really important that we've been able to staff because that's what has led us to be able to accomplish these things. Our urgent care volume and our transfers from the emergency department to urgent care have been relatively stable. This actually is different than it was before the pandemic. We never transferred as many patients to urgent care, and we've been much better about getting patients to the right level of care, especially between the emergency department and urgent care. The data for PES have not changed that much. It's still busy there. The med-surg data, which are reflected on page 13, you can see we're kind of stabling out at a higher level. I will just note that the census at 199 goes beyond our physical capacity for med-surg beds. And that's because of the very high level of boarders that we have in the hospital every day. Boarders are patients who have been admitted but are not in their beds in med-surg. So where are they? They're in med-surg. They're in the post-acute care unit, and they're in the ICU. Those are primarily the places. And when patients, we count among the boarders patients who are coming and staying for surgery, but we don't have a bed available for them. So you can see that, it's reflecting very high levels. The last thing I wanted to talk about was our lower level of care data. Dr. Day touched on this. This, of course, is really not where we want it to be. And there are very many complicated reasons for why our lower level of care data are so high. Of course, you know that Laguna Honda has not been available to us for more than a year now, but that is not the only reason. There are many patients waiting to leave who are at skilled nursing level of care, who are at residential level of care, who are simply waiting to go home. We have our length of stay now is a day higher than it was a couple of years ago, and a day extra length of stay in the hospital means we have 35 more patients in the hospital every single day. So this is a very complex problem. It is going to, we work on the things that we can control, and we try to work with a network to help us with the things we can't control, but it's very complicated. So I just want you to know that we're very focused on this topic. We're really trying to understand the data related to it so we can better understand the root causes. The last thing I'll say is related to vaccinations. So in a very momentous event, our vaccination clinic is closing at the end of this week. It doesn't mean we won't be vaccinating patients, but it does mean that they'll be vaccinated in primary care, which is where all other vaccines, for the most part, are being provided. Some in specialty care, but mainly in primary care. We provided almost 215,000 vaccinations in that clinic over time. And of course, it changed spots, but mainly recently in education and training, and almost 22,000 Mpox vaccinations. So it's a big deal. That clinic did amazing things for our community, and I just wanted to close by celebrating that clinic. And I can respond to questions now, and I also, Dr. Chow, have a response to the question you asked about the substance use on campus.
Good, yeah. Commissioner Green, why don't we go ahead with your questions?
Yeah, I laud you for these numbers. They're really terrific. I saw the lower level of care, and obviously there are challenges, but left without being seen or treated, and the diversion rate is remarkable. I never thought we'd get there, so it's really wonderful. I just really had two questions. One was, what's the mask policy going to be for patients and visitors?
The same.
The mask policy for patients?
The same.
The same, so
Yes.
they'll have to wear masks. So, so far our experience is we're giving out about 30 masks a day in my office alone because the public's very confused. And I wonder, given the number of entry points there may be at the hospital and on campus, will there be stations, or how will the public know that they still are in a medical facility that requires masking?
Yes. So thank you for raising that. So unlike before the pandemic, we only have 2 official entrances at the hospital right now. And though we are no longer screening patients coming in, we do have a presence there. We ask them where they're going, how we can help them, and we provide masks. I'm not aware of a count of masks provided every day, but it's a lot of them. So that's how we are making patients and visitors aware of that. Of course, our staff know.
Great, yeah, because I think people really are confused, and definitely will need masks. The other question is whether you have seen any particular demographics or diagnoses that seem to dominate the individuals who are in this lower level of care group. Is there any trend? Is there any particular subgroup that is more dominant in that population?
In terms of actual clinical diseases, no, but I think we do see some comorbidities associated with it. So marginally housed patients, patients with substance abuse, and then patients with coexisting psychiatric disorders. Those seem to be the top 3 diagnoses or social determinants of health that we see associated with our lower level of care.
Okay, thanks.
Commissioner?
Those are the main questions I had.
Thank you. If we followed up on that last question, what about in terms of socioeconomic issue for this group? That is the housed group, let's say, that's unreimbursed and that we can't move. And so if it's not clinical, homelessness probably plays a role, and potentially the ability to pay for even a boarding home or something like that. Is there quite a few of that? Because that would be then a citywide issue.
Right. So these numbers we look at very carefully every day. And so, there's around 40 lower level of care patients every day. Usually about half of them are waiting for skilled nursing. And that might be skilled nursing or custodial skilled nursing, which is almost impossible to find. The rest of them are really divided, and it's interesting. So there's a large group that's waiting for residential care or residential treatment. And we know that the availability of those types of placements is really impacted by the price of housing in San Francisco. There are far fewer of them, and there are fewer of them all the time because it's easier for owners to sell than it is to maintain those kind of facilities. Then, surprisingly, there are a large group of people who are waiting to go home, and they just can't, for a variety of reasons. They don't have an IHSS worker in place. They can't get the medical equipment they need. They're waiting on a family member. I mean, there's so many different reasons. Believe me, I grill our DOCC, our remarkable Department of Care Coordination team, a lot on this, and it's part of the challenge of this problem is that it's very multifactorial. You really can't, other than, you can name skilled nursing facilities, you can name residential care, but every patient is different, and every story is different, every circumstance is different. But I think, as Luke says, a lot of it is related to people having insecure housing situations, people having behavioral health diagnoses.
In terms of the policy, just going back to that for a moment, are we testing patients for COVID for admission or for surgery?
Yes. We still are, right?
Only for admission, not for.
Yeah.
So anyone who's admitted to the hospital, will be tested for COVID-19. So we continue that policy. But if you are coming in for an outpatient procedure or surgery, you do not require testing unless you're symptomatic or the provider requests it.
Interesting.
Stopped. Okay. Is that what you're doing?
No, they stopped testing.
They stopped testing.
Only people
period.
who are symptomatic. They completely stopped testing.
Yeah, that's what we understood at Chinese too from one of my colleagues. So I do think your policy is more conservative and actually more appropriate. I'm not sure why we have the other policy. So why don't we see if we can answer the question. I know that in the past we have talked about in the emergency room or elsewhere the issue of staff safety. And the article that came up really kind of generated that thought again. And I was just wondering where we were with this, and this is a public article that says, right, that a nurse had to be admitted because of coming into contact with a toxic substance. So I'm not sure what...
Yes. I'll preface this in two ways, and then I'll go into more detail about what we're doing. So first of all, we are doing a lot on this topic right now. We have always been doing a lot because of the specialized services we provide on campus, but this focus from the media has encouraged us to look at it again. I will also say that any details about any patients, as you know, we do not discuss because of HIPAA. And it's not always the case that what you read in the media about what happens with any particular patient is true. We just can't comment on it one way or the other. So we are balancing a challenging situation here because on the one hand, it is very clear that we are aspiring to be a substance-free zone. And that's clear in our policies, it's clear in messages that we give to patients and staff. So that is a clear thing. And we don't tolerate or condone the use of drugs by anyone on campus at any time. So I want to make sure that's really clear. At the same time, many of the people we serve suffer from substance use disorders. So it is the case that we always have patients who have substance use disorders. So we're balancing a circumstance where we know we have patients with substance use disorders and we don't condone substance use on campus. So that is a very challenging balance to walk. I know that at Laguna Honda, that's also been an issue that's been challenging to walk. Also, as substance use becomes more and more of an issue in the community, in our community, in the state, in the nation, that will be reflected among the patients we serve. So we can't imagine that if there's a lot of substance use in the community, that there won't be substance use in the campus. So our highest priority is to keep our patients safe, to keep our staff safe. And we have a variety of policies and procedures that exist in the hospital right now that we are re-looking at to make sure that we have adequately achieved that balance between not condoning any substance use on campus, keeping our staff and patients safe, and treating our patients with dignity and respect who have substance use disorders. So we have convened a number of different interdisciplinary groups to review these different policies and procedures. There are at least 5 of them that we know of right now that are related to this. And they are, they're all around this issue. So we want to make sure that we are reviewing those. And of course, they will come here to you. The other thing that we have at our, in our service is a very skilled addiction care team. And that team has proven to be effective. They've actually published on their effectiveness in reducing hospital readmissions for substance use disorders. So they are a part of this review and making sure that, that we are achieving this balance, as well as we can. I think that's the high level of information. I have obviously my colleagues here to help us answer more specific questions that you have, but I just want you to know that this is a topic we're taking very seriously right now, and we have a lot of work going on the campus to try to address it.
I think that your response is really very adequate and discusses where we all should be going. I mean, clearly at Laguna, this has been an issue in which they have been carefully, plotting what should be the policies that are kind of a balance, in their case, between residential rights and patient safety, and also, the problem and the need to deal with substance use. And so it seems to me that what you're doing here is to try to take an acute hospital setting and see what is really possible. I think that the media, of course, always, may look at a more sensational thing, and that was not the reason for my request. Actually, you've responded to my request with the right, in my mind, the right answer. Let's look at where we are and how we can strike that balance. So I'm looking forward to what you're going to be coming up with, just as on the Laguna side, we are following closely how we are responding at Laguna in regards to patients who need Laguna but have substance use issues too. And of course, in the acute hospital is somewhat different. So I would look forward to that. Commissioner Green, any thoughts on that also?
Pardon?
Any thoughts?
No, I really appreciate the answer, and I was also encouraged to hear about the staffing in the emergency department, because that's got to improve morale. So hopefully we'll hear some very positive feedback from everyone there that they feel taken care of.
Hopefully, yes. Thank you, Commissioner.
Yes, and I just want to compliment you. As you say on page 7, the responses on your left without being seen, and particularly the diversion, was remarkable, and I have it circled in big. This time we don't have to ask you why it's going up. Now we could ask you why it's going down. Right? So thank you very much. Let's proceed on to our next item then.
Great.
Thank you.
Item 6 is the ZSFG hiring and vacancy report.
Good afternoon, Commissioners. Emma Perez from CSFG HR Operations.
Could you get a little closer to the, it's almost like kissing it. I'm sorry to say that. Yeah.
Okay. So I'm here with the ZSFG HR Services Report. As you can see, we've remained about the same in terms of our vacancies. We're at 12.50 from February to March. We've hired a total of 33 employees between February 1st and February 28th in various classifications, including the RNs, and 6 of those were separations, of which 4 were retirements. Some of the factors that lead to that vacancy rate include a lack of qualified candidates and a lack of response from candidates once they're placed on eligible lists. Our RN vacancy rate increased to 13% this past month. And as you know, we continue to face these unprecedented challenges in filling the emergency care and critical care RN experience vacancies. We've noted that nurses continue to leave the workforce across the country, and we're seeing that in the headlines everywhere. So we're trying to be as creative as possible in trying to fill those gaps. We have RN recruiters who continue their recruitment efforts, posting job ads externally to our SF Careers job page in multiple platforms. They participate in job fairs. They establish partnerships with schools and other organizations. They have a whole network that they, that they try to source candidates from. To mitigate challenges in hiring nurses, we have hired 12 P103 per diem nurses this past month. Hiring managers continue to use application review, which speeds up the selection process, and giving priority to the existing per diem nurses to gain permanent positions. We're using our applicant tracking system to its maximum capacity, which includes the use of text communication. So not only emailing candidates and engaging them that way, but as we know, everyone has a cell phone, so we're texting candidates as well. Hiring managers are working to establish the cadence for the training programs. The RN recruitment hiring event in April will target both experienced nurses and trainees to fill our vacancies. HR continues to do the weekly and monthly vacancy meetings with our hospital executive team or program managers to review their hiring plans. So as far as the RN hiring status update for emergency care, there's 21 experienced vacancies. That's 18.82% of RNs in that specialty. And again, we just don't have experienced candidates to fill those vacancies. But we're processing a list right now with 2 candidates, so yay. We have a critical care unit, so 4 experienced vacancies for critical care. That's 11.02% of the RNs in that specialty, with 2 selections made with target start dates in April. For MedSurg, they have 27 experienced vacancies, or 12.31% of RNs in that specialty, with 1 candidate onboarding in March. For the OR, we don't have any experienced vacancies, but prior months, they're still onboarding, so we have 2.35% of those RNs showing us a vacancy, with 5 candidates onboarding in March. As far as our training update, I think this is really hopeful because I think we'll see a real uptick next month in terms of the positions that are being filled through the training programs. For the next critical care training program is anticipated April 17th with a cohort of 8. Our ED training program is anticipated July 24th with a cohort of up to 10. Unfortunately, the last training cohort that they had for the ED training program targeted 8, but of those 8, we ended up with 5 as we had some declines last minute. Our next MedSurg training program is targeted for April 1st with a cohort of 7 and a cohort of 15s on April 15th. Some highlights for non-RN hiring. We had 1 nurse manager for MedSurg, 8 senior eligibility workers, 1 industrial hygienist for health and safety, 2 medical social workers, and a maintenance planner. So that's our report. Did you have any questions?
Let's ask for public comment.
Sure. Folks on the line, if you'd like to make public comment on item 6, the hiring and vacancy report, please press *3. Again, *3. No hands, commissioners.
Thank you. Commissioner Green?
Yes, well, thank you for the report. I was wondering, if I recall right, a few meetings ago, we were talking about some of the hiring managers polling some of the people who declined job offers to figure out, what were the dissatisfiers or what were the issues. I know someone mentioned perhaps delays in hearing back, which I can tell you're correcting with the text messages. But were any data derived or any common themes from these interviews?
I can tell you from what I'm hearing, so some of the declines have to do with, especially now that we're hiring for the training programs, some of the candidates are reaching out to experienced nurses in their network, and they're asking them about positions in those units, and hearing that those units are very difficult, not at Zuckerberg, but just in general, the work involved is very difficult. And so they're having second thoughts about joining some of those training programs. Also, some individuals who live very far away, and just, again, making that decision about whether or not they want to have the long commute. I don't think we have any, that we have collected any specific data, because the data that we could collect is so minute that I don't know that it would be representative of, overall declines. But I don't know if nursing leadership has additional information to add.
Could you please speak in the...
Please use the mic.
Hi, good afternoon, Commissioners. Jillian Otway for nursing. What we have seen in the past when we've talked to a number of the applicants, if you're experienced, you tend not to want to work the night shift. And I think that is where we lose a lot of the experienced applicants. In terms of our hiring, we do really well with the training programs, and that's been our focus and will continue to be our focus. This recruitment fair on the 8th, we're really excited about this. We've done outreach to the schools, and we expect to have a huge turnout. This will be held at SEIU's offices on Rhode Island. They're partnering with us to do this. And so, again, we're hoping that we will be able to fill a lot of our positions with this focused event.
Great. One other question I had is, I don't know if you have any data about, we talk about the national shortage, of course, but do we have any sense of how our local Kaisers are doing, and whether they're having more success, and if so, whether they have any best practices? I mean, I know they give great Kaiser insurance to employees and families, but I'm wondering if we have any sense of whether it's pretty much a common problem, or whether they've figured out ways to recruit and retain.
I don't have any information on Kaiser. I will say that we recently had a labor and delivery nurse that left for Kaiser and returned to San Francisco General. So I'm always happy when that happens.
I can understand that. That one I get.
Yeah, because they can share their experiences, and then everyone else in the unit is pretty happy. So I don't know, though, offhand how they're doing in terms of their nursing recruitment and retention.
Okay, well, thanks.
Before you leave, talking about Kaiser, what about, in general, our salary structure? Do you think that that's behind? I mean, that was an issue before with radiology techs and all that we had, and then we had to reset the salary levels, right? So is that a big driver in, people not looking at general?
For the most part, we are competitive,
Okay.
and that happens when we sit down to do our negotiations at the table. We review all of the salaries that are paid throughout the Bay Areas, and we are competitive, I feel, in terms of salaries. And so I don't think that that's a huge issue for us right now. We obviously will be returning to the table with our bargaining unit in 2024, and so we'll reevaluate that at the time.
Okay, no, well, that's good to hear. Thank you. I think I just had, looking for the question I had, maybe we answered it already. Yeah, I guess in terms of, you remember the length of time that it takes to complete the process from application to hiring, has that been sufficiently reduced that we don't have that as a major obstacle now?
So there's always room for improvement. We have taken on a project to map the entire hiring process that was done in 2019, and we're revisiting it and updating it to see where we can cut down on time where there's waste and where we can improve on that. It's currently ongoing, so we don't have any additional information on that right now.
Well, when you finish that, maybe you can bring that to our attention as
Sure.
to whether or not you have a way of shaving even more days off.
Absolutely.
Because somebody waiting for 90 days sounds like that would be an awful long time after we made an offer. So, thank you.
Thank you.
Shall we move on?
Yes, please.
All right. Item 7 is the medical staff report, and Dr. Day is going to be presenting.
Hello again, Commissioners. So I am having the great pleasure of covering for Dr. Lisa Winston, who is on a well-deserved vacation right now with her family. So you have the medical staff report before you. I will start with the Chief of Staff report. So at our last MEC, our ophthalmology group was presented by its chair, Dr. Jay Stewart, who gave a very robust and impressive report, as you can see there in your packet. A couple of things to highlight. One, in the outpatient setting, you note that the ophthalmology service is the busiest outpatient specialty care clinic with nearly 20,000 visits a year. What is even more impressive is that for all of their services, they have a third next available appointment under 14 days, and in most cases, it is 7 days. They have been quite creative and innovative in their models there, really around the IVAN as well as teleretinopathy. With regards to the perioperative area, they have had some challenges here, which I think you are well aware of over the last several years of discussion around cataracts. They continue to add additional shifts within the ZSFG OR space, but they now have a collaboration with Chinese Hospital where they have a rotation of faculty that go over there on a weekly basis to do patients. That has been quite successful. They do about 30 to 40 a month, and this has helped reduce the backlog a little bit. While the wait time for cataracts was about 9 months before, it is now down to about 5 to 6 months. I think with these countermeasures in place, it should reduce it even further. And then lastly, as you can see on the education front, they are rated as one of the top locations for their residency program. Ophthalmology is ranked, I think, either number 1 or 2 in the nation in terms of the training here. They are well lauded for the education as well as the experience to work with our patient population and other providers and healthcare teams. With that, I'm happy to answer any questions regarding the ophthalmology annual report. And additionally, there are rules and regulations with the tracked and the non-tracked changes. Just to sort of highlight, there are no significant changes that were made. It was more just a little bit of wordsmithing.
Would you like me to check the public comment?
Yes, please.
Yes, sir. Okay. Folks on the line, if you'd like to make comment, we're on item 7, the medical staff report. Please press star 3 to raise your hand to make a comment. Star 3. No hands, Commissioners.
Commissioner Green.
Yeah, well, I was so impressed by the number of patients they see in the clinic. It's incredible. With the backlog in the cataracts, I think the pterygium too, I think we talked about that a year or so ago. Is it physician provider manpower or space? You mentioned that they've been able to decompress by using Chinese, or is it a balance of the two? Because I know, I know some ophthalmologists who go to places like Guatemala, and they do 1 cataract per patient so they can make twice as many people see. So but they also try to knock out 30 or 40 a day, and it's like 15-hour days and just moving as quickly as they can. So is it, and of course that's done on a very much, outpatient setting. So is it space or is it manpower?
Yeah, no, it's a great question. So in this particular case, it is more space for both. So for cataracts, while we would like to do it in the outpatient setting in the clinic, that is not a possibility at this particular time. They all have to be done in the operating room. And so we have limited space there, given that there are multiple competing services. There is some data to suggest that cataracts can be done in outpatient clinics. Our ophthalmology team has explored that, but we've not been able to move in that direction quite yet. With regards to pterygium, we have made significant improvements with regards to that wait time. Again, it's a space issue, but they've been able to do that within the clinic itself. And they do it, I believe, 2 to 3 times a week. And at one point, they were able to get that down below 14 days for their wait time with it. They do have a backlog right now for pterygium due to the COVID pandemic, and so they're just trying to work through that.
Great, thank you. That was the only question I had.
You mentioned that they're looking at the potential cataracts in outpatient clinics, but felt that they weren't able to do that yet. As we know, there are a lot of cataracts being done in outpatient clinics. So what were the impediments that they thought that this could not be a viable option?
The biggest impediment, from my understanding when we last looked at this, I believe it was just right before the pandemic, was around infection control. So some of the infection control measures that are required from a regulatory standpoint were not quite in place in our outpatient setting to be able to do it.
I see. Okay. So it isn't totally off the table, I guess.
It is not. No. Hopefully, in a couple of years, as we go through renovations within Building 5, that we potentially might be able to make those changes that would allow them to do it there. I will say, in terms of why we don't think it's a person power with regards to cataracts or pterygium, the ophthalmology faculty are quite willing to come in and do extra shifts in terms of doing procedures. So they are always one of the first to take on additional OR block space. If someone cancels, they'll put their patients in. So their faculty and staff are quite flexible and amenable to coming in and doing the patients whenever there's availability.
Okay. I was just thinking that if you actually had an outpatient clinic for cataracts, you would actually decompress your surgical facilities also and allow for increased flow for those that needed to have an inpatient setting for the surgery. In our case, it wouldn't be a matter of losing income, but a matter of improving our flow. But my other question is more an issue of grammar, I guess. In the ophthalmology rules and regulations, I've found that you are changing the word his to their.
Yes.
And so it sounds to me like we're making somebody plural.
I believe the reason for that change was to be gender neutral with regards to any reference throughout the document itself. You also know, for example, I think they had chairman before, so they just listed it as chair.
That I can understand, but the word there usually implies more than one person.
Correct. I can go back and check with Dr. Stewart about sort of their reasoning for that, but I believe it was to try to be as gender neutral as possible.
Commissioner Child, and today folks often will use they. When I list my pronouns, I use he, him, his. Some people say they, so that it's clear to address them in that regard. It's kind of a newer thing that's happened in the past few years, just in the gender world, and public health is trying to reflect. I didn't mean to jump in, but I'm trying to.
You're absolutely correct.
It's not an incorrect thing. It's a try to reflect the fluidity of gender, and so that language isn't gendered.
Oh, I'm not objecting to not gendering the language. I just think then we're going to have to change the definition of there. That's all. Not us. It's the world. Okay. Any other questions at this point? You have not actually then presented formally for our acceptance the rules, because you haven't then talked about the ambulatory care changes, right?
And I apologize, I wasn't sure what the protocol would be in terms of if you prefer to do the rules and regs or for me to do this, do them all together? Okay.
No, you're fine. Yeah, so why don't we go ahead with then looking at the discussion. You did the ophthalmology rules and regs telling us that, so we can go on to the summary changes for the ambulatory. And I think particularly, and I know there were questions that were raised, trying to understand also the role of PAs today under the new law, as Commissioner Green also, I think, sent to your attention.
Yes. Oh, another outstanding question. So before you is updates to 2 standardized procedures, one for the ambulatory care pharmacist, which would mostly just expand it to cardiology clinic, which would be greatly needed and is a robust service that helps our cardiologist. And then for the neurology standardized practice, it's mostly just updating it to be consistent with other SPs throughout the system. Regarding your question, Dr. Green, so this is a very dynamic and changing landscape with the new law. Our understanding is that it now allows nurse practitioners and midwives to practice independently. With that in mind, there is a team that has been formed network-wide, because this has implications beyond the ZSFG campus, to think about how we're going to incorporate this into our policies and procedures. No final decisions have been made as of yet, but as soon as we update those policies around it, we can come back to you and provide an update. I will say I don't anticipate the law to have any significant change with regards to the care provided by our nurse practitioners on campus. They work incredibly collaboratively with our physicians in many cases, and so it's more of a mutual synergistic relationship. And so while they operate pretty independently now, they work very closely with our providers, and they also work very closely with them to provide the best care for our patients.
Does that answer your question?
Yes, it was just interesting because it started January 1, and you can see, especially in areas where you're trying to open night clinics and weekend clinics, and then you're spread thin in so many departments in terms of physician staffing and even fellows and residents, that, it could be a real opportunity to increase capacity. And I gather there are some stipulations, though. You can't just decide, okay, I'm going to practice independently. You have to go through certain qualifications or some type of review. I wasn't sure what the details were, but I could see how it could be a real capacity builder if it's deployed in a thoughtful way.
Yeah. Our advanced practice practitioners have been a greatly added service to our system in terms of being able to increase and expand capacity across the entire network, both for primary and specialty care. My understanding of the law itself was more to aid those in geographically remote or rural areas where there may not be a lot of physicians in place to help supervise advanced practice practitioners, and so that's why I believe the law went into effect. I'm not sure if it applies to PAs, because my understanding for PAs that there's a certain percentage of their notes that have to be signed off by a provider, and so I'm not sure if that allows them to be practically independent.
Okay, so the changes here also does sound like, you're changing like the delegation of services to the word practice and all, which is that sort of anticipation of the changes that may be coming?
I believe it is, yes.
Okay. So you're asking us then for approval of these 2 items here.
Plus the rules and regs for the ophthalmology service.
Plus the rules, that's right, there's 3 items.
3 items, yes.
Okay.
Yeah, the 2 standardized practices and then the rules and regulations.
Oh, okay.
And again, the vote is to recommend to the full commission its approval at its next meeting.
Correct.
I would make that motion.
Okay, and I will second it.
Thank you. And so I'm reminded, and I apologize for this, that we're back into regular meetings, which means actually Dr. Ehrlich and Ms. Otway also vote, as well as some other people. So if we can do the old-fashioned,
Okay,
everyone in favor,
we'll
say aye,
ask for-
and,
okay. Oh, that's great. That's wonderful. Okay, so we'll ask for a vote on the part of the whole committee. All those in favor, say aye.
Aye.
And all those opposed, it passes without opposition. Thank you.
Thanks.
We recommend it to the commission for the consent calendar.
Yes, at
Thank
the
you.
April 4th meeting. Right.
Does everybody understand why we're doing this here in terms of going to a consent calendar now?
I'm
I
not
wonder-
sure, but it's a city attorney recommendation that the committee of the Health Commission does not have the authority of the full commission, and so any policies that need to be approved need to go to the full commission. And that's why a committee like this, or the ZSFG, or the finance and, the Laguna Honda JCC, or the finance and planning contracts are always now submitted to the full commission for approval. And that's why we do that extra step.
Right. So just want to be sure that, in case you weren't caught up to date as to our clarification of a process that the city attorney has asked us to do. So,
Right. Even though I don't think the city attorney does lean, they always are improving, and they found that this was something that they would like us to do. But let's move on to item 8, which is other business. Anything? Folks on the line, if you'd like to make a comment on other business, please press star 3. No hands. And we can go to 9 is general public comment. Folks on the line, if you'd like to make comment about something that's not on the agenda, please press star 3. I see no hands. So now you all can consider, it's item 10, closed session consideration.
Move to go into closed session.
I would second that. See if there's any public comment.
Folks on the line, if you'd like to make public comment about a closed session, item 10, please press star 3. No hand, no hands up. So
Okay.
again, this would be Ms. Otway.
For vote of everybody.
Yes.
Right. So all those in favor of going into a closed session, please say aye. Aye. Okay. And any nays? If not, we shall then move into closed session.
That's great. Okay, thank you. I'm starting the closed session. All right, we are back into open session.
Okay. So our next item?
Please consider a vote to disclose or not disclose discussions held in closed session.
Okay, so we need a motion to disclose or not disclose.
Move not to disclose.
Is there a second to that? Nobody wants to talk? I'll second it.
Oh, Dr. Ehrlich seconded it.
Oh, she did. I'm sorry. I didn't see that. Oh, it's just a high table. I didn't see your hand going up. Thank you.
And so, but you,
Take a vote. All those in favor please, of not disclosing, please say aye.
Aye.
Aye. All those opposed, there is no opposition. So we'll go on to our next point, which should be,
a consideration for adjournment.
okay, so we need a motion for adjournment.
Move to adjourn.
And I would second that, and we'll take a vote. All those in favor of adjourning, and I can see your hand. Thank you. And there is no opposition. We are then adjourned. Thank you very much.
Thanks.
Thank you, everyone.